So, good morning, everyone. As a representative of INEBRIA, I'm delighted that we can have this meeting here in Chile this year. It's part of our plan to expand INEBRIA beyond Europe and the United States, where most of the meetings have been held so far. So many of you who are attending here today, I believe, are at your first INEBRIA meeting. So I invite you, or urge you, to become members of INEBRIA. Being a member is free of cost, and you will gain access to a wonderful network of bright and beautiful people. So do join. Also, I should mention, for the local, or for the Latin American participants, we're also organizing a special get-together this afternoon. It's led by Dr. Marcela Tiburcio, who's sitting here somewhere. Right. At 5:30 this afternoon. I'm not sure exactly what room, but that will be, we'll know about that soon. You have this leaflet on your chairs, and 12:45 in a seminar. To the mic. Oh, there we go. Thank you. So, just a brief background to our thinking on this subject. While brief interventions are important in all countries, our sense is that it is particularly important in low and middle income countries. So taking a global view, because that is where drinking is developing, increasing affluence, increasing drinking. And this comes out in this report, which we heard about earlier, the Global Status Report on alcohol, which Dag Rekve, who I hope is here, has been very instrumental in putting together with Vladimir Pozniak in Geneva. Impressive work, a wonderful repository of statistics and information. There we go. We heard about this. But I think this is also important to bear in mind. Effective alcohol control measures in the interests of public health are especially important when rapid economic development is underway. And that captures our dilemma. Another piece of the puzzle is another recent report, just a few weeks back, from the Meta project, The Global Burden of Disease, which is incredibly impressive. But the message here is that alcohol is generally toxic. It improves disease and mortality at all levels of consumption, but it increases with consumption. But the conclusion is that the level of consumption that minimizes health loss is zero. And this is the underlying message and content of this report, that alcohol is toxic. It affects all biological tissues and leads to a long catalog of disease, more than 200 disorders. And this is the clinical reality of people in healthcare. We see this great panorama of people seeking us for all kinds of reasons, these reasons, and we don't think about alcohol. And that is our challenge, to help our colleagues, our practitioners, to think about alcohol when they encounter all these health problems. So we need a stronger response. The alcohol activities do not measure up to the scale of the problem, and we need to be better at this. But we also need to realize that alcohol is part of the body politic, that it affects all parts of our societies, transportation, education, agriculture, etc. And it needs a response on the policy level. So this is the Global Action Plan on Sustainable Development with a number of targets. And this is the third target, which is about health. And one of the indicators is on alcohol. Strengthen the prevention and treatment of substance abuse, including narcotic drug abuse and harmful use of alcohol. Fine. we're delighted that this is included. But how is the question? Well, here's an interesting view of that. OECD, which is not regarded as an alcohol organization, they took an economic view on what can reduce the cost of alcohol in different societies, doing modeling on existing research. And they took 3 cases where they looked at what different types of policy measures would lead to in terms of mortality and ill health. And interestingly, in all these 3 countries, screening and brief intervention comes out as the most effective approach. This is surprising to most of us. And the problem is that these are simulations or models, assuming that screening and brief intervention actually does happen. And we know that's not the case yet. So in fact, screening and brief intervention, since its inception in the 80s, has been an uphill battle. And we're still not there. So after 30 years of screening and brief intervention, with notable exceptions, doctors still do not, or practitioners don't ask patients about their drinking habits. If they do actually ask, they don't follow up with advice, typically. And should they give advice to some people, they don't have anything to offer patients who have more serious trouble with drinking. And they don't refer them to specialists. So this is our challenge, and this is a challenge of implementation. We have a good grasp of what is necessary, but we have not yet succeeded in implementing this in regular health care. So it's 2 levels. It's the professional level, to encourage, convince, etc., our colleagues to raise questions about alcohol. And on the policy level, our governments, our local authorities should require and support screening and brief intervention and integrate this in a national framework of alcohol policy. So this fits very nicely with the title of this conference, doesn't it? Challenges faced in the implementation of brief intervention in diverse settings, contexts, and population groups. So with these words, I just want to wish you 2 fine days, learning and inspiration. And I especially want to thank the organizers of this event, knowing how much work and effort has gone into this. Thank you.